All right, everybody. Thank you so much for joining us for today's town hall. I want to thank Aaronetta for being with us today for the presentation. Siley, I am going to turn it over to you to introduce our speaker today. Thank you so much.
Thank you, Krista. My name is Siley Tarlekar, and I'm the Global Marketing Director at Aaronetta, and I'm happy to introduce Dr. Das today. So we're honored to have Dr. Tony Das from Dallas join us today. Dr. Das serves as the CEO and founder of Connected Cardiovascular Care Associates and holds key roles as Chief of Cardiovascular Strategic Planning and Development, as well as Medical Director of Innovation and endovascular intervention at Baylor Scott and White Plano. The heart hospitals. Dr. Das made history as the first in the world to implement a second-generation cardiothoracic scanner called the Spotlight directly in his office for point-of-care use. We sincerely appreciate Dr. Das taking time from his clinic to share his invaluable experience with us. Dr. Das, the floor is yours.
Thank you so much. I hope everyone can hear me. That was a very kind introduction. I probably need to reduce the title so it makes it a little easier to introduce. So it's my pleasure over the next 20 minutes to go over 5 topics which I think have really kind of revolutionized the way that we assess patients with coronary disease in the office setting. One of the things that I think that is really changed is because of the guideline changes, we've had to reinvent the way that we evaluate patients and what our first steps are in assessing them. So let's start with an outline here. First of all, what we know is that outpatient ambulatory surgical guidelines have also changed for cardiac catheterization in the last 2 years. This, in connection with current cardiac imaging, has allowed us to incorporate newer tools for the assessment of chest pain. Subsequently, the guidelines for chest pain have also evolved, allowing us to use things like cardiac CT as first-line imaging opportunities. What we've learned in our practice is that because we have an active ambulatory surgical care center for doing procedures as well as inpatient opportunities, we can now really evaluate patients carefully and put them in their best location for the planning of their procedures. Instead of doing normal coronary arteriograms, we can actually stage, evaluate, and treat patients in the best setting for them. So let's get into it here. So what exactly has changed? So CMS and Medicare ASC guidelines changed, adding 14 new codes in January of 2020. Included in those codes was the ability to do coronary stenting for patients that were Medicare patients. So what happened is that this addition to the CMS guidelines allowed for elective outpatient intervention to be performed in the ambulatory surgical setting. So you'd ask yourself, how are you going to be comfortable doing coronary intervention in those settings? We personally have owned and been part of an outpatient surgical center, which was an OBL for many years and now is a hybrid ASC and OBL, along with about 10 or 12 other physicians. And we were able to do coronary intervention in those centers on commercial patients, but only starting in January of 2020 could we do them on these Medicare patients. So the first thing that changed was the CMS guidelines for ASCs to be able to do coronary intervention. Then what happened was that we noticed that when we evaluate patients, we wanted to make it the safest environment for them. So the typical evaluation for chest pain was an office evaluation to first understand the patient's symptom complex, whether they were stable or unstable or accelerated angina or chest pain. And then we did functional testing, typically a stress echo or a SPECT scan, sometimes an exercise stress test. But ultimately, we were unable to get both anatomic and physiologic assessment of these patients. And instead, we had to correlate those to the symptom complex and then decide whether we were going to do an invasive diagnostic cath. The part that didn't exist was coronary CTA, as many of these devices were expensive for practices and only available in hospital settings. And what we did know is that if we did a diagnostic catheterization on an abnormal nuclear stress test or a stress echo, that between 30 and 50% of those patients with functional tests that were abnormal may not have obstructive coronary disease. So we were cathing the wrong patients and potentially doing them in facilities that were overqualified to be able to do the most simple type of cases. So what happened next is that the guidelines not only changed for ASCs, but the guidelines changed for the American College of Cardiology, where first the European Cardiology Society, the ESC, changed their guidelines in 2019, recommending cardiac CT as a level 1 priority test. Cardiac CT was already adopted in several other countries, China, Korea, Japan, etc. And ultimately, this also came to the United States in 2021. The American Heart Association and the ACC, the American College of Cardiology, adopted the guidelines for chest pain diagnosis using CTA, coronary CTA, as a first-line recommendation for patients with both stable and acute chest pain. So this was a complete difference in the way we evaluated these patients starting in 2021, but access to these centers that had CTA were very limited, and especially centers that had CTA along with fractional flow or other imaging, which I'll get into in a minute. So now this is a level 1 recommended guideline. So what is this alternative evaluation for chest pain? Previously, as I said, it was nuclear scanning followed by a diagnostic cath, which 30 to 50% of the time may actually turn out to be normal. But now, using scans like the Araneta scanner, which we have in our office, we know that if that scan is normal, there's a very high 99% negative predictive value in knowing whether that patient has coronary disease. If we take the patient's symptom complex, the CT scan, and the SPECT image, and we put those 3 pieces together, we know how and when to assess these patients and where we might want to do their procedures. In the middle, you can see a CT scan from the cardiograph scanner, and then a SPECT image on a patient similar to that, which shows abnormal CT and abnormal nuclear. This is a patient that you would consider doing in a cardiac catheterization lab. Now, the question is, where would you do it? In a hospital, or would you do it in an ambulatory surgical center? And what would allow you to make the differential for each of those centers and keep the patient safe? What we learned is that in large scale studies, this is the Scott Heart trial looking at over 4,000 patients where CT was added to the workup. As we know, if you do a normal workup prior to the ubiquitous use of CT, standard evaluation included nuclear scanning, history, physical, etc. But if you added CT, look at the difference in not only the finding of coronary obstructions, but if you follow these patients over years, with standard care alone, you can see that the follow-up over 5 years, and that is mortality over 5 years, is drastically reduced by adding CT to the evaluation. So in 2021, that ACC-AHA guideline assignment of coronary CT for the highest level of evidence was based on data like this. Not only are you able to identify patients with this disease state, you can actually help their mortality by decreasing it using CTA as a first-line strategy. So what did we do in our practice? So we have a very robust outpatient coronary vascular valvular heart disease practice, and we partnered with Araneta. Unfortunately, when we did this, we moved into a new office, which was on the 3rd floor. So in addition to adding a challenging incorporation of a new device, we had to take 4 windows out of our building, get a crane set up, and between us and Araneta's scheduling and our excellent organizational staff, we were able to put this CT scanner on our 3rd floor. But what has it done for us? Well, essentially, we were the first in the country to put in this spotlight system. And when you're going to do something like this, which is very unique to a practice, you want to make sure you have the highest quality scanner. So this is not a 64 or 128 slice CT scanner, which is barely able to get coronary evaluation. This is a 560 slice CT scanner, rapid single heartbeat coverage of the entire heart with a 45 centimeter high resolution field of view for both coronary and diagnostic thoracic. We also have an extension on this to do lower extremity arterial. So we have state-of-the-art scanner added to our armamentarium. And what are we able to do with it? We're able to assess patients that have coronary disease and avoid doing unnecessary catheterization. But in addition to that, in this new age of cardiac CT imaging, what we know is that we can add a high-resolution CT scan along with physiology. So we are embarking on using heart flow analysis, which is a fractional flow analysis done without any intervention, but at the time, the algorithm or the CT, we add the heart flow algorithm, and we can identify patients that have a less than 0.8 fractional flow as important stenoses. So even when you have moderate to significant calcification, the stenosis may not warrant anything other than medical therapy. So here's an example of a heart flow analysis. You can see that blue is good and yellow is adequate and red is severe. And we'll show you some examples of red where the blood flow is reduced. And we can use that to triage these patients that need intervention or just need medical therapy. What we know is that this is a much higher diagnostic performance than other tests. So angiography plus FFR ultimately is an invasive procedure, but what if we could do it without an invasive procedure? You can look at the middle bar here shows a SPECT scan has an accuracy and appropriate use criteria of about 70%. The CTA alone over 80%, add fractional flow reserve, and you're now well into the 90%. And so that sensitivity and specificity allows you to do the right patient at the right time in the right location. So how do we use this? Well, when we add coronary CT and FFR, we can do things like this: avoid false negatives, avoid false positives, and reduce unnecessary procedures. Like I told you, 30 to 50% unnecessary procedures, we've basically avoided those. And we add significant amount of clinical clarity. So here's an example of a patient that has a heavily calcified coronary artery and a fractional flow reserve, which is blue on 2 arteries, but red on the LAD. And you can see that that severity of 0.53 correlates with this lesion. And so we know this patient not only needs a heart catheterization and an intervention if symptomatic, that we know where we can do this. So here's an example of 2 patients that had nuclear stress tests that both looked relatively borderline. The first one on the left is a 55-year-old patient with atypical chest pain, and this scan, which shows evidence at stress of decreased blood flow in the apical infralateral regions, and at rest there's improvement, so there appears to be ischemia. And this is a 55-year-old patient whose symptoms are not very convincing, but you have this scan, and previously we would have just gone to heart catheterization with this patient if the symptoms were more classic. On the right is another patient, much older, 86 years old, with mild chest pain and a significantly abnormal nuclear stress test. Stress is on top and rest is on the bottom. So what's the dilemma? Should you take these patients to the cardiac catheterization lab? So enter our Araneta scanner and our fractional flow reserve, and it tells us, wait, on that first patient with atypical chest pain, yes, there is narrowing, but none of the narrowing is severe. You can see it's mostly blue and green. On the next one, there's multiple oranges and reds, which means the blood flow is severe. However, the disease is pretty distal. So can I manage this patient that has a significantly abnormal nuclear stress test that has distal disease at an elderly age with just medical therapy? So again, the nuance here is that there's a severity of disease, but we don't have to go ahead and intervene on this patient because we know the severity of the disease is pretty distal. We would not have known that without CT and fractional flow reserve, because the 2 nuclear scans were almost identical. Both of those patients would have ended up with a coronary angiogram. So here's another example of a patient who has an eccentric plaque in the main LAD. CT FFR shows that there's a significant reduction in flow reserve. Patient has also a lesion here you can see in the circumflex. Well, we knew by CT FFR that the circumflex lesion was not critical, and so we did not have to proceed with doing an intervention on this patient. Instead, the LAD lesion, which you can see here, evaluated by intravascular ultrasound, and then followed by balloon and stent, is now widely patent with a coronary stent in the LAD. Again, right patient, right time, and right procedure. We didn't have to do anything to the circumflex. We avoid contrast, we avoid radiation, and we do the procedure that the patient actually needs based on anatomy and based on physiology. What we know in conclusion is that the primary role of coronary CT and FFR in stable patients is only going to increase. We recognize that coronary CTA by guidelines is now a first-line evaluation for patients with chest pain. In addition to that, we have patients that have poor warning systems. They may be diabetic or have other conditions, and this detects undetected disease by nuclear scanning. It also, most importantly, reduces unnecessary procedures. I'm an interventional cardiologist, and the last thing I want to do is a normal diagnostic cath. But if the patient needs an invasive procedure and an intervention, I also want to know, how can I aid my clinical decision-making for my invasive procedure by adding these tools? And ultimately, I can tell whether the patient is safe to be able to do, for instance, in an outpatient cath lab, an ASC, or whether they need more complex evaluation, maybe in an inpatient setting. So what's continued to evolve in this space is not only the quality of this CT scanning, but also now fractional flow reserve and plaque morphology, both of which are covered by insurance carriers, including Medicare. And why? Because they recognize that the likelihood of knowing what type of disease the patient has is intensified by having both anatomic and physiologic information. Fast followers to heart flow include algorithms like Clearly and ultimately Elucid. These are just other groups, other companies that have the ability to assess patients' coronary CTAs if at high quality, which the Araneta scanner is giving us high quality CTs, we can then look at the physiology of these. So it's been a fantastic way for us to plan. Our ambulatory surgical center now gets the appropriate patients without having patients that should be in an inpatient setting or a hospital setting. And we also are able to triage those patients and plan on the interventions more properly. I wanted to thank Araneta and my partners at C3. Here you can see our technician. We were actually published in this Cardiovascular Business Journal as the first dedicated cardiac CT in the US. And it wouldn't be without a good partnership with a group that has been able to help us make this come to fruition. And our reading physicians, you can see Dr. Nicholas McPherson here in the middle and Dr. Raymond, who's probably closely behind him reading these studies. I just want to thank the team here for our ability to sort of change the paradigm in which we evaluate and assess patients in 2024 with coronary artery disease. Thank you very much for your attention.
Thank you, Dr. Doss. That was a fantastic presentation. I want to take a minute to open it up to those that are on the call to see if they have any questions. You can raise your hand or you can just unmute.
Dr. Doss, I have a question for you. First, thank you for taking the time, but can you talk a little bit about the patient journey as far as how long before it would take a patient to get a CT scan or cardiac CT scan versus now with your practice?
Yeah, it's a great question. I mean, access to care is kind of a buzzword, but it's not really just a buzzword. It's actually a real dilemma in the United States and other places where patients can't even get the scans done. When we were doing coronary CT for the last couple of years and referring them to the hospital system, it would take 1 or 2 months to get a scan done. We now are attempting to do these scans same day or next day in the practice. But in addition to that, we have the ability to start a chest pain protocol where patients that may leave, for instance, an urgent care setting. We had conversations yesterday at a couple of urgent cares, and they were really enthusiastic about the fact that if they had a patient that they tried to get into a cardiologist, it was often weeks or months before they could even just get into a cardiologist, much less get the testing done. And we're able to shorten that whole pathway into less than a week and maybe sometimes even less than a few days. So good question. And I think it changes the workflow analysis for these patients and also reduces the number of patients that may get lost to follow-up. But we know in one of the hospital systems that I work with closely in town that about 18% of the patients that come in with chest pain into the emergency room. That's about 10,000 patients a month in all of their facilities. Only 18% of them end up getting a follow-up evaluation or scan in the following 3 months. Why is that? Because some of them just lose interest because they haven't been able to get followed up, or there's not access to getting into a cardiologist. So this really will help reduce that backflow or that backup of patients. It's a good question, Dan.
That's a great question. That's a great comment. I also wonder, could you comment on any challenges that you've had with insurance?
Yeah, I mean, I think that once you have level 1 guidelines, it becomes a lot easier. I remember over the last few months, we would contact the insurance company to get approval, say, for instance, for a nuclear scan or a stress echo, and they would ask us, have you done a CT yet? So it's really becoming the insurance companies have also led with understanding that the guidelines do consider CTA as a number 1 level guideline recommendation for chest pain. So we're not having a hard time getting that approved. And we just had a call with some of our colleagues that you guys are very familiar with in capital cardiology and also the folks at Dooley. We understand that CT along with FFR is also in their regions is also highly approved and reimbursed. And so I think the key here is that all of the payers are starting to recognize that this is probably the test that ought to be done first. Access to it may be tricky though.
Right. That's a great point. That's really encouraging. That's good to hear. Thank you for sharing that.
Sure.
Does anyone else on the call have any questions for Dr. Doss while we have him? All right, well, hearing none, thank you so much for the presentation and for being with us today. And we look forward to hearing from you again.
Thank you very much for the invitation. Bye-bye.
Bye.
Thank you.